Hi, everybody, and welcome to the Kidney Coach YouTube channel. I'm naturopathic Dr. Fiona Chin, and I'm joined again today by the amazing Dr. Alex Grinberg. Now, if you haven't listened to any of our previous podcasts, Dr. Alex is a Californian-based physician based up there in San Francisco, if I remember correctly. And he's in private practice working with patients with lots of chronic diseases, including things like kidney disease. But he's trained in virology, psychology. He works with many integrative physicians. Psychiatry. What did I say? I made some nice word up. So he's very well versed in everything, but, works hand in hand with many other integrative practitioners and doctors. He was just telling me, yesterday he was on a call with a nephrologist going through the latest clinical studies to get the best outcomes for patients, which is something we're going to talk about today. So he's also got a huge interest in longevity medicine and peptides. He's probably the most knowledgeable person, he is the most knowledgeable person I've ever spoken to when it comes to peptide medicine. He started his medical degree when he was 15 years old, which again blows my mind. So he's been in this field for a long time. It's what he lives and breathes and is very good at it. So anything else you want to add to that, Dr. Grinberg? I know you've got, I know you head up many biotech companies. I know you're still on the board of lots of studies that are coming up. I know you're on one of the ones here in Australia, in Adelaide. I mean, your credentials are very far reaching and broad, but also not broad in the way that you're not specialized, because I know you're very, very good at dealing and working with people with chronic diseases and really getting at the root cause and really thinking and contemplating about the best way to support them. And, what I always appreciate about you is if you're not quite sure, you've got these amazing team of practitioners, whether they be oncologists, nephrologists, that you'll work with. So, which is also really amazing, which means your breadth of knowledge just continues to evolve every time I talk to you. So anything else you wanted to add there that I've missed?
Well, thank you so much, Fiona, for this generous presentation. Thank you.
So what we're going to talk about today really is some of the latest drugs that we're using in chronic kidney disease. But what I really liked, and I was just talking to Dr. Grinberg before we hit record, was just the nuances of knowing when to use certain drugs in particular cases with kidney disease, and how to ask your nephrologist which one would be right for you versus, whether it's a blood pressure medication, a diabetic medication. But there are such nuances that will make a huge difference in the outcome that you get if you are going down the Western medicine treatment route and you decide to incorporate pharmaceuticals, about choosing the drug that's absolutely the right one for you. Because as a patient, we're not trained in that, and we assume that our physician is giving us the best drug. And I know from my own journey with things like, having MS, I know that most of the disease-modifying drugs don't work on spinal cord lesions, but no one will tell you that unless you talk to the top specialists that will say, yeah, actually, they're not going to work on that. So it's these sort of nuances that I think patients, whether they've got high protein in the urine, whether they've got IgA nephropathy, we'll get into this, but knowing exactly which drugs to use and when is something that we're going to help our audience get a little bit of a grasp around today. Is that right?
Any organ, any physiological system in our body has so many different cells, so many different tissues, and so many different processes happen there at the same time. And unfortunately, that creates also potential for having multiple pathological conditions or diseases affecting the same organ. And it's very true for kidney, that the kidney is extremely morphologically, physiologically a complex organ and responsible for so many different processes in our body, that naturally there is a big room for having different pathological conditions. And there are different forms of nephropathy, different forms of nephritis, different forms of inflammation happening in the kidney. It may happen both in different areas, like medullary inflammation or inflammation affecting cortex tissue and other tubular system. But all kinds of inflammation can be different also. Different cells may be involved in both inflammatory reaction and also in the this particular kidney inflammatory response. And this response definitely depends on this patient genetic setup, having different genetic predispositions. And this is very complex area where hopefully soon enough we'll have treatment based on reading our individual genomes, but while it's not available, there are still a lot of studies that happening in real time, and I would recommend patients when they get some medications recommended or administered by the physician, ask based on which study and representing patients with which form of kidney renal pathology, what percentage of positive outcomes they observed, and on the positive outcome we understand slow the progression of CKD or reversal of some symptoms, and whatever the criteria for this particular clinical study is. So physicians working in the specialties like nephrologists working with renal problems or hepatologists with liver problems, they are well trained, and they have an access to check the clinical trials and what's happening. And it's very important because a lot of new medications were brought to the nephrology over the last 10-15 years, different classes of medications that control blood pressure, different classes of medications that control absorption and tubular absorption and reabsorption, like CGLT inhibitors, also medications that affect other aspects of processes that affect kidney, like parathyroid hormone and vitamin D metabolism, and also for advanced stages of disease, newer materials and compounds were brought to facilitate dialysis to make it more efficient. And talking about the broad range of medications, they all have different role in different stage of CKD. If one medication are known to improve outcomes in intermediate or like a second or third stage, it may not be so if someone has stage 4 or 5. It also depends on the presence. Efficiency may depend on morphological or histological changes in the kidney. And again, every patient responds differently to different pathological processes. Some people have, like, say, a pyelonephritis for many years, and somehow there is no general inflammatory process inside their kidney, and we don't see significant renal impairments related symptoms like renal hypertension or some other complications. But at the same time, other people have pyelonephritis for relatively short time, and we see all kinds of complications that they develop very fast and almost like a textbook picture. So obviously it depends on a genetically determined pattern of how tissues and particular groups of cells respond to the same insult, be it some infectious agents or inflammation related to some other processes in the body. Same with diabetic nephropathy. Some people have diabetes for many decades and their kidney are doing relatively well. And some people develop diabetic nephropathy is almost the first complication of diabetes, right? So that's why it's so important to see, like, for example, someone is using CGLT inhibitors, and how to differentiate between each class of medications. Each family of medications also has some subpopulations. And interestingly, all these seemingly not very different medications may have different indications, outcomes in different specific types of, like, nephritis or neuropathy. nephropathy, and also may depend on the stage of the illness. So the let's say chance that they give good outcome versus chance that they give some side effects are useless depends on so many different factors. That's my main point. And I would encourage CKD patients ask their doctors based on which study they recommended, let's say, one kind of CGLT1 versus another kind, how exactly it works for their stage and for the imaging or biopsy results that the doctor has. How basically I encourage people to ask the physicians to check how well they integrate all available data on specifics of their conditions and specifics of this particular class and particular name of medication in this class.
So up on the screen, you've given me a list of all the 7 drugs that have been launched in the US for chronic kidney disease. So, walk us through just a high level of those, because you've obviously got everything from SGLT2 inhibitors to ACE inhibitors, and then we've got the vitamin D one. So from a high level, just walk our viewers through the sorts of drugs that they may have been put on and why, and then we'll get into some of the slides that follow this.
So before I do this, I just want to mention to our viewers that in integrative medicine, there are nice terms like we talk about kidney brain axis, kidney thymus axis, kidney lung axis, kidney pancreas axis, kidney endocrine system axis, and so on. And so when we see this integral picture of how organ functions and how it's connected to other organs, I would add this word axis commenting on each drug. For example, first one is Benazepril, and it's ACE inhibitor. It's basically it was developed as an antihypertensive medication. So that's why I have to mention this word kidney or renal vascular axis. So there is such a huge interrelation between vascular status and kidney status. One affects another, and it's like a circle. So just briefly, kidney like to have good perfusion, a good amount of blood going through them, both for their own sake to feed them because their cells are highly active and they need a lot of oxygen, a lot of energy to do all multiple functions that they have to do. At the same time, they need also to filter sufficient amount of blood to detoxify the body. And for this reason, kidney make sure that even if something happens in the body, they create enough pressure to perfuse them very well. That's why they produce a lot of molecules that some people call kidney hormones. So they have, most of them are vasoactive substances, so they regulate. Finally, they regulate hemodynamics, how much blood, at what speed, and at what pressure it would come to kidney. When this is dysregulated for different reasons, there is unnecessary release of these substances. They constrict the blood vessels, and the blood pressure automatically goes up. And at the same time, even when people don't have kidney problems, but they have hypertension, high blood pressure for different reasons, eventually it harms the kidney because all this, in simple words, this high impact of blood that is liquid against the walls of blood vessels makes them harden. Because they need to resist this high pressure fluid flowing through them. So there are multiple systems involved, from activating genes that produce these factors that make smooth muscles tougher and tougher and more rigid and eventually even osteogenic factor that makes this previously smooth muscles fibers turn into something like bones calcify, and that people probably heard about this calcified coronary arteries, and there is a special index for this, but they're all also calcified glomerular arteries that may be even worse because they're extremely fragile and very delicate arteries. And so when we reduce blood pressure, either for hypertension that was not related to kidney problem, that some kind of, let's say, idiopathic hypertension, or when we reduce blood pressure related to kidney problem, it's a win-win situation because it protects blood vessels, and don't forget that blood vessels are everywhere in your body and very dense in your kidney. So if you protect blood vessels, you automatically protect and improve your kidney. And this is endless subject because we can protect, we can improve blood vessels, and they also made from different tissues, from the lining and epithelial to deeper levels and deeper levels. And each of them that has its strengths and vulnerabilities. So just little sidekick about peptides. Peptides are so powerful because many of them improve expression of genes related to different layers of blood vessels, endothelium, and smooth muscles, and cell extracellular matrix that is very important, and each of them affects something like proliferation of fibroblasts or fibrin deposits, or also helps to avoid autoimmune reaction against all these damages. That's why peptides have such a pleiotropic effects. It means they affect many systems. So back to our medications. So Benazepril is not the only one used. It's just an example. There are so many AC, and depending on the country, each country, many countries have their own brand names of AC inhibitors and ARP, angiotensin receptor related medications. But again, the question patients should address to their physicians is why this particular one is selected for this particular patient treatment, because also all of them are pretty well studied. For pharmacological companies do a lot of ongoing studies and publications on there. They try to pinpoint populations that respond best to these medications and will avoid having side effects. And this study is available online, so hopefully physicians can check them and discuss it with the patient.
Okay, so the Benazepril will be for people with hypertension. So then talk to me about the calcium modifying released drugs.
Yes, and talking about this, actually, I just want to make smooth transition from talking about hypertension. So calcium is also, while most people think that good calcium is associated only with good effects, at the same time, many apoptosis-related, apoptosis means cellular death processes, are related to excessive calcium or malfunction of the receptors that are responsible for transport of calcium across cell membrane. That it's very interesting. Receptors are very sensitive, and some chronic inflammatory syndrome or metabolic syndrome may affect these receptors and eventually may affect calcium transport across cell membrane, and it triggers all kind of nasty processes, like it affects mitochondria, it activates pro-apoptotic genes, and it affects probably negatively lipid peroxidation and formation of reactive oxygen species. So what happens as kidney also involved in metabolism of calcium and vitamin D.
Mhm.
There are receptors in, now we're talking in terms of integrative medicine about renal and endocrine connection, because this parathyroid gland has receptors to calcium and has receptors to the molecules related to vitamin D, probably. It's
Mhm.
secondary products. And usually chronic kidney disease is associated with low levels of vitamin D and impairments in metabolism of steroid hormones, and also because of complex mechanisms related to transport and excretion of different electrolytes, it affects levels of calcium. In turn, it affects parathyroid gland to produce this parathyroid hormone. And probably people with CKD know that their physicians frequently order PTH test. And
Mhm. It should be, yes.
yes, and also an extremely important element that we have to mention is phosphorus, and phosphorus
Mhm.
very closely related to calcium and to calcium metabolism. And phosphorus also people probably know, and it's different molecules with phosphorus, not easy on kidney. And people with CKD should be very selective with foods and see phosphorus content there. And without going to the depths of biochemistry, phosphorus very involved in calcium metabolism and vice versa. And for this reason, medications that provide, let's say, stabilization or function of parathyroid renal system, they prevent kidney from continuous damage by increased levels of phosphorus and unregulated calcium levels. And in turn, also unregulated calcium levels can inflict further damage on renal renal cells endothelium, and so this is ongoing and self-sustaining damage.
Mhm. Okay, so what about the sodium glucose transporters, the SGL2s? And I know you've got a couple of them there, but they've been fairly new sort of drugs being brought in for kidney disease and diabetes that have got some pretty amazing results. So walk me through these next two drug classes and the SGL2 inhibitors.
Yes. So this class of medication helps to excrete more glucose. It affects tubular reabsorption of glucose. And this class of medication was actually created because of huge worldwide problem with diabetic nephropathy.
Mm.
And these medications, by reducing the blood levels of glucose and all related unpleasant things like excessive protein glycation, and also triggering all kind of apoptotic and inflammatory signaling, by reducing basically this medication reduce the progression of diabetes, and by doing this, and actually by the action, they probably reduce ongoing insult from higher glucose levels that diabetic patients have. And this provides significant protection for people suffering from diabetes, but there are also some nuances. We discussed this different, there are about 6 or 7 GLP-1 medications now, and there are ongoing studies of why and what is the indication for each particular one. And also, I had a question, should CKD patients that have borderline level of blood glucose or borderline diabetes, could they think about this medication, or even if this medication should be taken prophylactically?
Mhm.
People who don't have a diabetes.
It's a good
So
question.
yeah, would they be preventing people from developing diabetes and or reducing the impact of uremic factors on the endocrine system,
Mhm.
particularly on pancreas? So there is no agreement about this, and there are ongoing studies about this. But these medications are well proven. They definitely help people significantly slow down progression of chronic kidney disease. They improve their metabolic status. Many people take them in combination with metformin. And
Yes, that's what I was going to ask, because a lot of people are using metformin as a longevity drug. So I was wondering whether people might be very specific about saying, well, is metformin something if I've got chronic kidney disease and just slightly mildly elevated blood sugar? Should I be looking at using something like metformin that's maybe got a better safety profile and has all these other benefits?
in my opinion, yes, because metformin was the, I would say, mostly longevity medication for people who have indication to take metformin to start with. And research showed that for people who have mild or not so mild type type 2 diabetes, it was helping them to, so it was extending lifespan. For healthy people, again, it would depend, I would believe, on genome specific responses to different levels within, or even within normal range, different levels, blood sugar, because again, everyone can identify with this. Some people tolerate fasting very well, but other people respond so dramatically to dropping levels of blood glucose, blood sugar. Again, it's all very interesting question, and patients probably have, they know their bodies well, they have some observations, and they can see how these medications help them. But definitely metformin for people who have medical conditions, it's I think it's it has a bonus of rejuvenating medication in addition to medication that is medication of choice for their particular conditions.
Interesting. Okay. Okay. So anything else you want to say about the SGLT type inhibitors before we move on to, I think we've got the Icodextrin, which is a peritoneal dialysis type drug, right?
Probably about GLPT, if people, sorry, if patients have questions about their potential side effects, and this question is actually relevant. This question is relevant for asking about any of prescribed medications, because medications within the same group and the same family, they may have different adverse effect profiles. So there were studies that some of SGLT1 may have increased risk of palpitation. Another one have another risk for headache or changes in arterial blood pressure. So this is a question to ask, because even if there are no significant statistics on this and this side effects, if there is difference in the side effect profile, people may benefit from knowing this and selecting this SGLT1 or any other medication from this list in general. It will be very helpful. And also, this research, the studies available usually on internet, people can also check this research themselves, and it's always good to be educated patient and be a part of decision making with any physician.
100%. I totally agree with that. So tell me about Icodextrin.
Well, this class of molecules, medications, created for peritoneal dialysis, and we should always uh, keep in mind that a lot of patients are on different forms of dialysis, and for them, it's very important to help them to feel well, to give them more energy, to improve their life quality and feeling of well-being. And I'm glad that the industry develops better and more efficient molecules that make the procedures more feasible to perform at home, to maintain life quality, and to be more efficient. And again, for people on dialysis and for people with different forms and stages of CKD, it's extremely important to maintain the nutrient status. Because, sorry, in between the medications, I wanted to add this because people on dialysis know how important it is to maintain levels of certain ions and electrolytes. It's very important for everyone looking for longevity interventions or improving any clinical conditions, because people should realize that a simple thing as sufficient hydration is necessary to deliver their red blood cells to the peripheral tissues and the kidneys, so coronary blood vessels to feed heart muscle. But if there is not enough hydration, the blood cannot viscosity of blood is thicker, viscosity of blood is getting higher, and just can't deliver enough carriers like red blood cells to particular organ and tissue. So that's important of circulation, maintaining good circulation. And I know, Fiona, you practice traditional Oriental forms of medicine, so it's cheese, availability, accessibility of chi to any part of the body depend also directly related to microcirculation.
Absolutely.
Better microcirculation, and I'm sure better microcirculation, better energetical process related to chi. So at the same time, that's how it's important to maintain exercise regimen, because your the cardiac output would be high, you will deliver more. Eventually, you will deliver more nutrients to your target organs that struggle with some illness or with aging. It's so important. And so hydration, maintaining appropriate coagulant status of the blood, it's extremely important because formation of microclots is affecting severely kidney, and also atherosclerotic different development also affects all this fragile and delicate glomerular nephron structures and blood vessels. So back to dextrin. So any materials that facilitate process of dialysis and help to maintain normal homeostasis are welcome, and it's a good addition to people dealing with nephrological problems arsenal.
And tell me about the phosphate binders, because these are such an interesting one. We touched on phosphate binders when we talked about the calcifediol and the vitamin D, and it's, you know, one of the things that I found in a lot of the research with kidney disease and the relationship to clotho is that we know that clotho is a determinant of kidney disease, and that high phosphate levels affects the FGF23. And when your FGF23 goes up, your clotho declines. And that is potentially one of the early mechanisms behind a decline in kidney function. We don't have tests for it. I'm pretty convinced that if we could properly test for that, we would be able to pick up people that are going to be at risk of kidney disease 10, 15 years before we see a shift in EGFR numbers and things like that. So phosphate binders are things that are generally used a little bit later. But again, is there any prophylaxis with phosphate binders? Are they only used sort of at the time when we need them? Sort of walk me through phosphate binders, when you'd use them and what they look like, because I find the whole phosphate GF23 clotho pathway really fascinating when it comes to kidney disease.
Yes, actually, I'm happy to hear your question if there is any prophylactic value in this, because that's one question I asked my friend who is nephrologist and
Yeah, right.
consultant.
What
Yeah.
did he say? Because I am fascinated by this.
Yes. It's extremely important in nephrology to regulate level of phosphorus first. And actually, phosphorus triggers many destructive processes when it gets filtered by the kidney, and kidney as a main filter organ has to have to deal with huge amounts of phosphorus, and frequently even when people have normal diet. But as also just as a useful information, people should realize that phosphorus very closely correlates with vitamin D levels, and it's interesting. People with different nephrological conditions frequently have a low vitamin D level, and nephrologists don't recommend to push it too high. I think it's important for people to know, because people like to use some different places for vitamin injections and treatments like this. But for people with renal problems, vitamin D level should be around 35, and they shouldn't push it too high, because it will cause the increase of phosphorus level that would be counterproductive and damaging for the kidney. Reducing the level of phosphorus definitely helps people in most stages of CKD. It's probably not so important when people have dialysis, because it helps these people to filter the phosphorus. But definitely slows down progression, and probably differently in different stages of CKD. There are studies showing how this medication affects progression, how it slows down development of CKD, depending on the stage, and probably some other parameters. And prophylactically, again, our audience should realize that usually pharmacological companies interested in testing for disease population, because there they can prove that there is margin of benefits, that it helps some people with target condition, and probably would be very illustrative for FDA to prove it. But at the same time, if they pick up the subjects for clinical research, healthy people, it's more likely that people will talk about having side effects than having some benefits. So understanding this logistics, it helps to make our own opinion that it wasn't studied well, and it's unlikely it will be studied well. So probably if people have a luxury to do frequent testing and to follow up, and they try it prophylactically if they have some borderline kidney issue, and when they calculate the daily phosphorus intake, it's still high because they need to eat and maintain the level of activity. Probably they may benefit from this medication, but again, it's up to people to decide, and they should discuss it with their physicians, and up to people to discuss if to consider this as a prophylactic treatment.
Okay.
And again, I would recommend studying a lot of studies about this medication side effects, because consider that the risk of potential adverse effects may outweigh risk of potential benefit.
Yes, because phosphorus is still important and needed. So
yes. At the same time, we know how many medications now use as repurposed drugs, and they have I would say remotely related to initial target positive side effects. So it's a very interesting study, and again, please get as much information about this medication and side effects and discuss it with your physician.
And the last one on the list is the Sarvez, so which is obviously, I think that's another cardiovascular medication. Tell me more about that.
This medication brings us up to the discussion related to diuretics. And people probably noticed that there were gradual changes in the physicians' practices, switching for using one diuretic mostly 15 years ago, switching to a little different one 10 years ago, and now having even long-acting diuretics like this one. So again, it also it all depends on the clinical status of the patient. For example, if someone has pulmonary edema and a lot of swelling in his or her body, and it's affecting cardiac function, it's better use the diuretics that help relatively fast, because it's dangerous to prolong this overload by fluids in the body. It can cause some catastrophic conditions. At the same time, if people have just need for chronic diuretic, there is nothing urgent. Probably a long-acting diuretic is a better option. Again, would depend on pharmacokinetics, pharmacodynamics, how long it stays in the body, how abruptly the concentrations drop in the body. And again, I'm sure people will tell me that some of them tried long-acting diuretic, some of them prefer to take diuretic daily, and not using long-term diuretic, and everyone has positive results, and I can explain their preferences. And again, I think it also depends on genetic setup and genetic predispositions, and on little but significant nuances and differences between particular form of renal condition or nephrological condition. There's many different forms, and I'm sure people suffering from CKD know that certain diuretics they tolerate better, certain diuretics they feel they tax and burden their kidney, and they feel general feeling of suffering when they use this diuretic. Or in some people, even worse, this diuretics may escalate or accelerate progression to renal fibrosis.
Yes, I've definitely seen that. And I've got a question for you back up to the ACE inhibitors. Why would you use, say, an ACE inhibitor over a calcium channel blocker? So I noticed you didn't have a calcium channel blocker on there, and it's, you know, like, what is because there's so many for hypertension, you just mentioned diuretics, we talked about the ACE inhibitors. Is calcium channel blocker still something you'd consider for kidney disease, or is it something that shouldn't be due to the recent studies, and that's something I need to be updated on, and patients maybe need to know about as well?
Yes, I think that's ACE inhibitors considered first because there is angiotensin system and receptors in kidney, and for this reason it immediately targets both hypertension and I would say relates itself to kidney receptors and substance produced in kidney. That's why, and also there are a lot of studies giving positive reviews of the ACE inhibitors for particularly in people with renal hypertension and hypertension that affects kidney. But at the same time, most patients are on combination of ACE inhibitor and second or third antihypertensive medication, as many people use calcium channel blockers and it helps them very well. Actually, they see that combination of these agents works better and satisfies their needs better, and they have more stable control of blood pressure. But there are a lot of studies, again, about all these nuances, how to combine different classes of antihypertensive medications and what consideration should be given to so many other variables, like someone has frequent cardiac arrhythmia and takes beta blockers. Someone has pulmonary condition that requires using beta stimulant medication. So many different considerations, and so again, there are very thin edge between using different subgroups of medications, and it can be figured out based on a very thorough review of patient case, specifics of his diagnosis, biopsy, or other indications of specifics of this nephrological process, and then considering at what stage of this patient disease, what activity with disease of this disease, this medication is most beneficial. And but answering the question about calcium channel blockers, yeah, they are a big part of treatment of cardiovascular conditions, hypertension, and also probably another important issue why IC inhibitors are used. Please check the studies about prevention and prophylaxis of major fears that we have for people with, particularly with chronic kidney disease, strokes and major cardiovascular events. And it's very important. Most likely, this AC inhibitors show better rate of preventing such outcomes. And as people with chronic kidney disease have many folds increased risk of this cardiovascular catastrophes, I think it's another important contributing factor in making this medication of choice. Yeah.
I mean, I often just see, I mean, I don't know what it's like in the States, but in Australia, people are generally going to see the general physician because they've got elevated blood pressure. The physician hasn't flagged that there's a decline in kidney function, which we see, you know, so EGFR might be sitting around 50. It's not being flagged. They're not seeing a nephrologist, and the GP is managing blood pressure without understanding kidney function. And they're often, whatever the latest pharmaceutical rep has been out and told them which drug is best for blood pressure. And I've often seen patients with a decline in kidney function on a beta blocker or a calcium channel blocker for 1 to 2 years with minimal, like it's improved blood pressure a little. Maybe it's come from 150, 160 down to 135, which I'm like, you've already got a decline in kidney function. That's still too high blood pressure. And they're not, because they're not trained or nuanced and they haven't looked at the decline in kidney function, there's not this, what you're talking about, which is a much more nuanced understanding of kidneys and the relationship and looking at that. And I don't know, again, if it's that's in the States, but that's the major problem we're seeing here in Australia is doctors not referring on, not seeing a decline in kidney function as being an issue, and missing a real big opportunity to actually control blood pressure properly so it doesn't continue to further decline kidney function. It's an ongoing frustration of mine. So is that something you see in the States as well? Because I always feel for my poor old kidney patients when they've come in and I'm like, we could have got your kidney function back up to normal if we'd got you when it was an EGFR of 53 and now you're at 27 because the blood pressure hasn't been properly controlled because your doctor hasn't known the nuance of maybe starting with an ACE inhibitor and maybe trying a diuretic or something else, or trying some dietary intervention. Is that something you see as well?
You know, it depends on level of availability and quality of healthcare that particular patient gets. But among the doctors, I see growing awareness and getting a second opinion from nephrologist more. It's more frequently asked. And yeah, and also, of course, patients' education is very important. And on so here I want to give advice to our audience. Also if you start a new medication or you're not happy with the effects of your current medication regimen, would be better to get more frequent blood tests, even routine ones like all this creatinine, BUN, and EGFR would be helpful, even if you check them every few weeks when something is changing in your treatment regimen, would be good and in today's medicine, most informative feedback on what's happening.
I think that is excellent advice, Dr. Grinberg. So I totally agree with you that when you're changing medication, and I would even say that extends to when we're putting in natural remedies, although they take natural remedies don't act as fast as a pharmaceutical, but more regular blood testing to make sure it's moving the needle in the right direction is, I think, fantastic. I just had a patient send results through this morning using our herbals, and the EGFR moved, and the BUN and the creatinine were moving every month. So for him, it had a very fast, rapid action, which is great. And it's jumped 10 points in 6 months, which is fantastic. But yeah, I totally agree with that. I think that's a very, very good point that people should definitely be encouraging to work with their GPs for that.
And next secret or bonus I want to give our audience is, please be attentive to your urine pH. It's very important. It's very important. And I would strongly recommend to people with CKD trying to reverse this condition, trying to improve, make sure that the urine pH gets closer to 7, between 6.5 and 7. And if it's 5, we don't like it. It means there is a significant acidosis. Probably it reflects significant metabolic acidosis. And what happens? Previously, I mentioned that red blood cells carry a lot of nutrients, including oxygen, but also how about all other nutrients, minerals, and some other molecules and fuel. When there is acid environment, these transporters cannot unload and transfer it into the cells, because this acid environment between cells and the blood and target tissues and organs precludes or prevents these nutrients from penetrating into the target tissues. Actually, acidosis even precludes these nutrients from getting into red blood cells. That's why now, luckily, we have nutrient determination based on their level on red blood cells, and we see that even people who get frequent vitamin injections or take enough supplements, their levels in the blood plasma may be high, even higher than normal, but the red blood cells nutrients, the same nutrients level may be low. So this is a significant mismatch between the level in the plasma and the tissues and cells, and you still starve your cells because they cannot get food because of acid environment. And so probably you understand how important it is to make sure, and there is a simple feedback way, just check urine pH. And urine exams analysis cheap and can be also done frequently, and particularly with the purpose to see if you improve your pH, and it reflects all necessary changes in lifestyle. If you eat properly, you hydrate enough, your urinary pH will improve. All right, Fiona?
Yeah, 100%. It's part of our program. So we get people to actually urine test every day. And of course, that's why we encourage an alkalizing diet. And that's why we see such good results using alkalizing diets for this exact reason. So you're transporting nutrients inside the red blood cells and out of the tissue. So we're not getting so much oxidative damage there. So very, very important. And that, a couple of my patients will talk about, or they're in our mastery group, they'll talk about that when their urine pH is much better, their heart rate variability that they're mapping on their Oura rings or things like that improves. So it's having a huge impact on the whole nervous system, which I find super fascinating. So yeah, lots of great things when you get your pH in the right levels.
And and other important things that are very cheap, not expensive and very available, accessible. For frequent check of your blood electrolytes. So people with CKD is very important for probably everyone knows about potassium levels, but potassium levels can create different cardiac events that are very unpleasant. And even if someone has not advanced form of CKD, but potassium levels started changing abruptly, and then at least be aware of meals, foods that contain high level of potassium can save someone's life, right? Because it can
Yeah, although Jesse, Anna, and I have a very different take on potassium with the new rules that came out. We now know if you take out potassium when you shouldn't, when it's not indicated on a blood test, it'll accelerate the decline in kidney function. So I'm anti-removing potassium foods only unless a blood test fully warrants it. And then oftentimes we find it would be due to imbalances in salt intake and often medication. So I don't often see a major potassium balance when it's done properly. That's just my thing in the latest research I've been looking at. So, but yeah, open to seeing some other studies on that. But yeah, I've just seen the updated guidelines and they're saying the same sort of thing. So yeah, very fascinating with potassium. I think it gets a bad rap for no reason.
All electrolytes, potassium, phosphorus, sodium, it's very important. It's probably soon we'll have wearable devices that will be able to determine.
I think so. I don't think that's far away.
We're going to some already. Because also, I'm just mentioning the things that can significantly facilitate dealing with this condition and actually give good outcomes and reverse the condition. Frequently monitoring your blood glucose. Even people who don't have diabetes, they may find out what kind of food gives them more significant spikes and how they respond to it, so they can. It all disciplines people and helps them to stick to healthier and CKD prevention or mitigation lifestyles. Then
100%. CGMs are great. I was just going to say those CGM wearable devices are, I think everybody with kidney disease should wear at least 2 weeks of that because you can definitely see spikes. What else do you want to say to anyone before we wrap up this amazing podcast? Are there any other, there's been some great tips and tools in there, but especially when it comes to the bloods, medications, but anything else you want to add before we finish?
Yeah, there are a few very important things. So renal brain connection, we should consider this. And it's not only related to associated with vascular damage or high blood pressure damage in the brain, but it can come from uremic toxins, from increase ROS and NOS, reactive oxygen and nitrogen species, and activation of so many inflammatory pathways, because actually presence of these renal toxins affects blood-brain barrier, and many molecules that not supposed to get through and be in the central nervous system between neurons. They affect synaptic function and even deeper on epigenetic level. Neurons. That's why people may easily develop some cognitive impairments and accelerated dementia. Or
foggy brain's probably one of the biggest symptoms that people talk about when they've got itchy skin and foggy brain when they talk about kidney disease.
And again, if the medications that we discussed and the appropriate use can slow down progression and prevent brain from being damaged, it's also very important. And again, it's up to physician to see what is most dangerous for the brain, where it's coming from high blood pressure or from increased phosphorus or creatinine levels. So then to make judgment which of these medications may reduce this damaging factor more. So you see how many things should be taken into consideration.
Yeah, wow. It's funny, no one talks about the renal brain connection. We might need to do a full podcast just on that, I think, Dr. Griffin.
And definitely people with mild CKD ignore or just not willing to discuss it, but many of them have chronic depression.
Yes, very true.
People mood and
we should definitely do a deep dive on the brain renal connection because I don't know anyone talking about it. So
And when people have depression, their melatonin production in the brain suffers. But melatonin is important to support kidney and to prevent apoptosis of nephrons.
Exactly. Yeah, fascinating.
Also, there is renal brain connection, renal pineal connection, evidenced by changes of diurnal circadian rhythms in people with CKD, and at the same time improvement if they're able to restore these rhythms, whether with the help of melatonin or certain peptide. And this we see good results. And another useful and not expensive marker is blood ammonia level. Some labs do this, and it's not expensive test, but it correlates with mitochondrial damage. Is the level of mitochondrial damage. And again, people with CKD may benefit very well from kidney-friendly submolecules that improve mitochondrial function. There are some supplements. Of course, one very well known is alpha-lipoic acid and glutathione, but also some peptides are very, very useful for restoring mitochondrial function. And and also when people do fancier testing, they this CKD may statistically significantly affect average telomere length in this group of patients. And for this reason, supplements or integrative medicine interventions like peptides that improve telomere health, they also help kidney cells to survive better and to slow down or start moving on apoptotic pathways. And they also are useful to prevent kidney oncological conditions like kidney carcinoma. And if people suffer from this condition, they help to slow it down. Yeah,
fascinating. Okay. Any other words of wisdom before we wrap up? And we'll definitely do another podcast. I definitely want to get into the blood-brain renal connection and talk about peptides specifically for that.
Maybe you have 2 more questions, and I will be happy to answer.
I think you've answered it all. They were the big questions about prophylaxis and a few other bits and pieces. So you've answered everything I had already. Excellent. If you want to know more about Dr. Grinberg, I'll put his details in below. You can connect with him. He obviously is a California-based physician there, but and he does telehealth and online consultations. And I've sent a few of my Australian patients to him. As I say, he's probably the most knowledgeable person when it comes to peptide intervention and the best way to use them in any sort of chronic disease. So he's my go-to for that sort of stuff. But as well as just any integrative medicine, he's obviously got a very good handle on working with chronic diseases and works with a big resource and team of other practitioners. So I will put those details in below. Make sure you hit like and subscribe. That way you'll get notifications anytime we put up a new podcast. If you've got any specific questions for Dr. Grinberg, put them in below and he will answer them, or I will send them across to him. And we look forward to seeing you next time. Thanks again for being part of our community. If you want to know more about us, head to www.kidneycoach.com. Bye. Thanks, Dr. Grinberg.
Thank you, everyone. Get better, get well, and get healthy.